Pancreatitis channel. It's me, Maria, and today I'm with you to explain the pancreatitis. Before talking about pancreatitis as a disease itself, I want to discuss some anatomical thing about the pancreas. First of all, you need to know it is a retroperitoneal organ occur in transpyloric plane. It divided into head, neck, body, and tail. It occurs in the curve of the duodenum. Here is the duodenum, and this is the pancreas. It is there's some structures lie posterior to it, inferior vena cava, concavity of portal vein, superior mesenteric vessel, as I draw here, the red one, very large vessel, and celiac plexus, crura of the diaphragm, left kidney, and even suprarenal glands. There's also blood vessels or blood supply of the pancreas, which we have two. The first one is pancreatico-duodenal artery, and the second one, which is the tortuous one and occur on the upper border of the pancreas, it's called splenic artery, which is a branch of the celiac trunk. The corresponding vein drain into portal system. Also, it had lymphatic. It's occur on the upper border of the pancreas, and also it is along the superior mesenteric artery. Okay, now here is the acute pancreatitis. What is the definition? I'm going to take with you the definition, the signs and symptoms, the investigation, and how we treat the patient. First of all, this is the duodenal, as I said before, and here is the little sweet pancreas. And then, what's going on here? First of all, it's an inflammatory process. So, in this process, you may lose some pancreatic cell. Okay, lead to a sudden onset of pain. It is mostly epigastric, and this pain associated with increased level of pancreatic enzyme, which is amylase and even lipase. The gland can be back to its normal state if the cause will treated very well. So it is a reversible disease. The controversy of the chronic pancreatitis, it is irreversible. So now here's the examination. The second thing is a sign and symptoms. How your patient will come to you. Mostly patient come to ER. He will complaining of severe epigastric pain. This pain is severe, sudden in onset. It is radiating to the bag, so don't miss this pain. So it's in the epigastric area, here is it, and it's radiated to the bag. Associated with what? Associated with nausea, with vomiting. Your patient will come in shock, as the case of hemorrhagic pancreatitis. Now, what do you do by examination? First of all, you will find tenderness in the gastric area. Maybe you can't find it all over the abdomen. Second thing, you will find absent bowel sound, and there is also abdominal distension. Try to examine your patient carefully. So I'll cover the patient and look for two important signs which is lead you to the pancreatitis and also lead you to the specific type of it. We have two important signs. First one, it is called Cohen sign, and the second one is called Turner Gray sign. The Cohen sign, it is a bluish discoloration around the umbilical, and it will lead you to hemorrhagic pancreatitis, while a gray tunnel sign, it is in the flank, also bluish discoloration in the flanks, and it is lead you to pancreatitis, wherever the type, but Cohen is specific for a hemorrhagic pancreatitis. Now we will talk about the causes. 60% is a biliary disease, 20 of them are alcoholic. Now we have other causes such as hyperlipidemia, hyperparathyroidism, viral infection such as Coxsackie or even mumps. We have trauma, okay, and post-ER CV. So be careful when you're taking your history. Also, there is some autoimmune with polyarteritis nodosa. some drugs such as the contraception, azathioprine, thiazide, and also diuretics. Now we'll talk about the investigation, how you investigate your patient. First of all, do CBC. In the CBC, you could find completed blood count that hemoglobin is low. Patient is in anemia because there was, especially in the types of hemorrhagic pancreatitis. Second thing, you will find WBC is high because inflammatory process. Then try to do urea and electrolyte. Maybe there is disturbance. Liver function test because AST is gonna be high in the patient who had acute pancreatitis. Amylase, it will be so specific and it is more than 1000 units per liter. Now calcium is decreased. You will find the glucose is high, there is a hyperglycemic state, and the oxygen is maybe low. Also do ECG. In the ECG you will find there is a diminished in the C wave. Be careful about one thing, that patient who had hemorrhagic pancreatitis, he will come with amylase in normal state. Why? Because there is an extensive destruction of the pancreas, so you could find it normal. Also you will do what? Abdominal x-ray. You're gonna find there is absent psoas shadow. You can also do chest x-ray. In the chest x-ray you will find a small pure effusion amount. And last thing is CT scan. CT scan, it could lead you to necrosis if there is abscess, and it can do assessment of severity for you. Now, prognosis. How you do your prognosis about something called Ranson criteria. This will help you in the prognosis and how you treat if it is mild case or even a severe case. Ranson criteria, we have first of all age, about 55. If it is more than it, so it's dangerous. WBC more than 60,000. Also we have glucose. Glucose, it will be more than 11 millimole per hour. LDH more than 350 international units per liter, and AST is more than 600 international units per liter. So the complication, pancreatic necrosis, abscess, maybe even pseudocyst forming. Maybe he will come in acute renal failure, ARDS, acute respiratory distress syndrome. Also he will come with some maybe relapsing acute pancreatitis, diabetes mellitus, and gastric erosion. Gastric erosion, your patient will come with hematolysis and melena. So you have to be careful because it is maybe he will come in the complication, not as I mentioned before. So maybe he will come vomiting blood, or even there is a black tear stool. How to treat this patient? First of all, it is no better oral. Nothing had to give by mouth to this patient. Nasogastric tube. It is also so important. IV fluids such as crystalloid, colloid, maybe blood if patient needs blood when hemoglobin is low. Follis catheter just to measure the urine output. And we have to give analgesia such as betadine. Try to cover your patient by antibiotics such as maybe we have metronidazole, cefuroxime, proton pump inhibitor just to prevent the gastric erosion. Calcium gluconate because the patient is hypocalcemia. Start enteral feeding. 10 ERCV with a bile duct stones. Last thing is surgery. What is the indication for surgery? Uncertainty of the diagnosis. You are not sure about your diagnosis or even deterioration in the patient's condition. So we will need the surgery to drainage of the abscess. Removal of necrotic pancreas may be required. Fat necrosis may be seen at the laboratory. Also drain of acidosis. In early cholecystectomy if there is a gallstone. Thanks for watching. Please like, subscribe and comment. See you in the next videos. Bye.